ফার্স্ট হচ্ছে গুড মর্নিং, সেকেন্ড হচ্ছে কনগ্রাচুলেশনস অ্যান্ড লাভ to all who have passed the exam of FMT and community medicine. Now, recaps of the previous class to clarify and to rectify certain statement by me in the previous class. I have uttered a wrong unit related to the cardiac index. I had told the unit of cardiac index is ml per minute per square meter of body surface area. That is wrong. It would be liter per minute per square meter of body surface area. Sorry for this mistake. Second, clarification of the apex beat and the cardiac auscultation. আমরা এপেক্স বিটে যে জিনিসগুলো দেখি বা দেখার চেষ্টা করি সেগুলো হচ্ছে লোকেশন, ডিরেকশন, ডিউরেশন, ডায়ামিটার, অ্যাম্পলিটিউড, ক্যারেক্টার, টাইমিং and the association it keeps. In a setting of heart failure, apex beat may be forceful and well sustained, forceful and ill sustained, diffuse, dyskinetic and displaced as in the case of LV aneurysm, and double apical impulse in the setting of hypertrophic cardiomyopathy. That's all. And auscultation, I have missed a very important thing. It is the S3. S3 is a virtually pathognomonic of heart failure, especially in a setting of volume overload with elevated LV filling pressure. So S3 in conjunction with tachycardia produces S3 gallop. Again, S3 is related to the volume overload or increased ventricular filling and is an important parameter in the clinical diagnosis of heart failure. S4 is not specific for heart failure, but S4 is occasionally audible in a setting of systolic stress or in a setting of pressure overload like aortic stenosis or hypertension or hypertrophic cardiomyopathy. Auscultation reveals S1 that may be normal or diminished or soft in intensity or shows variability in intensity due to AV dissociation or presence of arrhythmias, especially atrial fibrillation. S2 is usually normal or accentuated due to the accentuation of pulmonary component. There may be the functional regurgitation murmur of mitral valve and tricuspid valve. That means murmur of mitral regurgitation or tricuspid regurgitation even in absence of structural mitral valve or tricuspid valve disease. Now today's topic, the diagnostic workup and the management. A high index of clinical suspicion on the basis of history and physical examination. That means on the basis of symptoms and signs as a result of congestion and the low perfusion. High index of clinical suspicion on the basis of symptoms and signs resulting from congestion and low perfusion is corroborated by investigations and other imaging studies for confirmation of diagnosis. Second, identification of an etiological process. And third, the risk stratification in an attempt to launch the opposite therapeutic strategy. First of all, history taking and physical exam, lab test, CXR, electrocardiogram, and obviously echocardiography. Then determine the cause. The investigations are cardiac magnetic resonance imaging, CT, cardiac tomography, and PET, positron emission tomography. Then coronary angiography, screening for amyloidosis, sarcoidosis, hemochromatosis, etc. And lastly, endomyocardial biopsy for identification of the etiologic basis. MRI, CT, PET, coronary angiography, screening for the amyloidosis, sarcoidosis, hemochromatosis, and lastly, endomyocardial biopsy. Then the risk stratification, NYHA functional class, then cardiopulmonary exercise testing, then natriuretic peptide levels, then ambulatory rhythm monitor, then hemodynamic profile, and lastly, family history. Now, summarizing history and physical exam, symptoms and signs from congestion and low perfusion, high index of clinical suspicion, supplemented by the investigations in the form of lab test, CXR, ECG, echocardiography for confirmation of diagnosis, identification of the etiologic basis, and the risk stratification. For confirmation, determination of the etiologic basis, CMRI, CT or PET, coronary angiography, screening for the amyloidosis, sarcoidosis, and hemochromatosis, lastly, endomyocardial biopsy. Risk stratification depends on NYHA functional class, cardiopulmonary exercise testing, and the natriuretic peptide levels, ambulatory rhythm monitor, hemodynamic profiles, family history of cardiovascular diseases. Now, routine lab test. First of all, routine lab test, a comprehensive metabolic panel, complete blood count, coagulation screen, and urine analysis. And in selected cases, screening for diabetes mellitus, dyslipidemia, and thyroid function test. Then chest X-ray, then ECG, then non-invasive imaging that include echocardiography, MRI, CT, and PET. Lastly, cardiopulmonary exercise testing, তারপর আসছে biomarkers, and lastly, invasive studies. The comprehensive metabolic panel, complete blood count, coagulation studies, and the urine analysis. In selected cases, screening for diabetes mellitus, dyslipidemia, and thyroid function test. Then CXR, ECG, then non-invasive imaging, then cardiopulmonary exercise testing, then biomarkers, and lastly, invasive studies. CXR, what are the changes? Enlargement of the cardiac salute with a cardiothoracic ratio exceeding 0.5. Then upper zone vascular or venous redistribution known as cephalization. Then pulmonary edema, a butterfly pattern of opacity that is fanning out to the periphery of the lungs. Lastly, Kerley's V lines, that is, the thin horizontal linear opacities extending to the very pleural surface. Now repeating, CXR, enlargement of the cardiac salute with a cardiothoracic ratio exceeding 0.5. Number 2, pulmonary venous congestion. Number 3, upper zone venous redistribution known as cephalization. Then a butterfly pattern of interstitial and alveolar opacities bilaterally fanning out to the periphery of the lungs. And lastly, Kerley's B lines, thin horizontal linear opacities extending to the pleural surface caused by an accumulation of fluid in the interstitial space, especially distension of the interlobular septa. Now, stages of heart failure and the radiological changes. This is the vascular pedicle. This is the azygous vein, redistribution of the pulmonary blood flow, that is cephalization, pulmonary edema, Kerley's B lines, and pleural fluid, and increased heart size or cardiac salute. Stage 1. This is the stage of redistribution. That means PCWP 13 to 18 millimeter of mercury. The features are redistribution of the pulmonary vessels, cephalization, cardiomegaly, and broad vascular pedicles. This is the vascular pedicles. Stage 2, interstitial edema, PCWP 18 to 25 millimeter of mercury. The features are Kerley's lines, peribronchial cupping, hazy contour of vessels, and thickened interlobar fissure. Stage 3, alveolar edema. That means PCWP more than 25 millimeter of mercury, producing consolidation, air bronchogram, cotton wool spot, and pleural effusion. Chest X-ray showing Batwing appearance or butterfly appearance. This is the one wing, this is the another wing. The classical butterfly or bat wing appearance of the lung fills. Increase in the cardiothoracic ratio, widening of the vascular pedicle, and prominence of the upper zone vessels. This is the Kerley's lines. Kerley's line গুলো তিনটে হতে পারে, Kerley's B, Kerley's A, and Kerley's C. What is Kerley's B? This is the classical of the heart failure. Linear thin opacities due to edema or distension of the interlobular septum or accumulation of fluid in the interstitial space. This is the Kerley's B line. Thin horizontal lines in the mid and lower zone extending to the pleural surface. This is the Kerley's B lines. What is Kerley's A lines? This is the thin line from the periphery to the hilum of the lung fills. This is due to the anastomosis between the systemic and pulmonary lymphatic channels. Dilatation of the anastomotic lymphatic channels between the central and the peripheral lymphatic system or drainage. And what is the Kerley's C lines? This is the reticular formation or reticular opacities or reticular changes in the lower lung base coming from the end on of the Kerley B lines or in face of Kerley B lines. This is the Kerley C. This is the Kerley B. This is the Kerley A. And this is the Kerley C. Again, there is increased cardiothoracic ratio. ECG. ECG may show stigma of a disease like old infarction or arrhythmia in the form of atrial or ventricular ectopic activity or atrial fibrillation, atrial flutter. Then, no changes are specific. But in setting of heart failure, two things to be remembered. One is systolic strain and the second is the diastolic strain. What is the systolic strain? Evidence of LVH by means of voltage criteria. Then the ST segment depression with convexity upwards and the blunt apex and the ascending limb. This is the asymmetry. এক কথায় ST segment depression with convexity upwards associated with blunt apex of the T wave, and that is totally asymmetric. That means the descending limb and the ascending limb is asymmetric. Example, ST segment depression, convexity upwards. This is the ascending limb, descending and ascending, totally asymmetric, and this is the blunt apex. This is the systolic overload or systolic strain or strain pattern. What would be the diastolic overload or volume overload? This is the prominence of the Q wave, tall upright T, and LVH or LV enlargement. So pressure overload, LVH with systolic strain, volume overload. This is the LV enlargement and the diastolic overload. These two crucial changes should be remembered or considered in a setting of heart failure. So ECG changes are ectopic activity, either ventricular ectopic activity or atrial ectopic activity, atrial fibrillation, atrial flutter, or cardiac dysrhythmia of any sorts, and then fluid overload or volume overload and pressure overload changes. This is the normal QRS configuration with the ST segment and T wave, and this is the normal Q. This is the pressure overload, this is the volume overload. Non-invasive imaging, first echocardiography. Two-dimensional echocardiography provides an accurate and rapid assessment of ventricular size and function, valvular morphology and function, and can detect intracavitary thrombus and pericardial effusion. Then the cardiac magnetic resonance imaging, an accurate and quantitative tool for assessment of LV mass, volume, wall motion abnormalities, and determine the specific etiology of heart failure, as for example, ischemic cardiomyopathy, myocarditis, amyloidosis, etc. who cannot undergo CMRI due to placement of the intracardiac electronic devices, we should go for CT, that is cardiac CT. Cardiac CT is useful for pericardial disease and the detection of LV apical thrombus. When MRI is not feasible, then we should go for cardiac CT that can detect pericardial disease and LV apical thrombus. Then PET, cardiac positron emission tomography. The extent of myocardial ischemia and injury or infarction in a setting of coronary arterial disease, and the degree and distribution of inflammation in case of sarcoidosis can better be understood by means of cardiac positron emission tomography. So, the extent of ischemia and infarct in a setting of coronary arterial disease and the degree and determination of cardiac inflammation is done by PET. Then cardiopulmonary exercise testing, an objective assessment of the peak pulmonary blood flow, peak functional capacity, an objective assessment of peak functional capacity in a subject being evaluated for cardiac transplantation or mechanical circulatory support. So, an objective assessment of the peak functional capacity for a patient being evaluated for mechanical circulatory support or cardiac transplantation. Then the biomarkers, circulating levels of cardiac biomarkers, especially BNP and NT-proBNP, is an adjunct in the diagnosis of heart failure, especially in case of uncertainty, that means clinical uncertainty, and second, presence of concomitant lung disease. So biomarkers are useful in a setting of uncertainty. Second, in a setting of presence of the concomitant lung disease. NT-proBNP level exceeding 125 picogram per ml or BNP level exceeding or equal to 35 picogram per ml is suggestive of heart failure, but cardiac biomarkers are not specific for heart failure. It may be elevated in both certain cardiac as well as non-cardiac conditions. Lastly, invasive studies in the setting of intensive care unit, assessment of cardiac filling pressures and cardiac output is essential to differentiate cardiogenic edema from non-cardiogenic edema, as for example, ARDS produces non-cardiogenic pulmonary edema. So in invasive studies, especially in the intensive care unit, assessment of the cardiac filling pressures and cardiac output to differentiate between the non-cardiogenic and cardiogenic pulmonary edema, as well as better understanding of the hemodynamic profile to manage the hemodynamic instability. Now, compromising all these investigations, we should approach for a diagnosis and classification. Assessment, clinical history, physical exam, ECG and lab test. Then natriuretic peptides, NT-proBNP more than or equal to 125 picogram per ml, or BNP more than or equal to 35 picogram per ml. Then transthoracic echocardiography and additional diagnostic test if necessary. Confirmation of diagnosis of heart failure, then determine the cause and classify. Heart failure with reduced ejection fraction, that means LVEF less than equal to 30%. Heart failure with MREF, that means heart failure with mildly reduced ejection fraction, যেখানে ejection fraction 41 to 49%, and heart failure with preserved ejection fraction HFpEF, that means LVEF exceeding or equal to 50%. Evaluate for precipitating factors and initiate treatment. Classification, এটা খুব গোল মেলে। Classification by means of type, functional status, hemodynamic status, and so on. It may be acute or chronic, it may be systolic or diastolic, it may be right-sided or left-sided or combined biventricular. As for example, heart failure, low cardiac output heart failure, high cardiac output heart failure, low cardiac output heart failure, right-sided heart failure, common causes, left ventricular failure, then pulmonary stenosis, then lung disease, that means chronic or pulmonal. Left-sided heart failure, that may be systolic failure, that may be diastolic failure. Causes of systolic failure, ischemic heart disease, dilated cardiomyopathy, valvular heart disease, and hypertension. Diastolic heart failure, hypertension, restrictive cardiomyopathy, constrictive pericarditis, or cardiac tamponade. And the high cardiac output failure, anemia, pregnancy, thyrotoxicosis, arteriovenous malformation. Now stages of heart failure, এটা মাথায় রাখতে হবে। হার্ট ফেলিওরে যে যতগুলো কথা বলা হলো সবগুলি বেসিক্যালি খুব একটা কাজে লাগবে না, কাজে লাগবে তিনটে পার্ট। স্টেজেস অফ হার্ট ফেলিওর, classification of heart failure on the basis of LV ejection fraction and NYHA functional class. এই তিনটে প্যারামিটারকে ইনকর্পোরেট করে থেরাপিউটিক স্ট্র্যাটেজি ঠিক করা হয়। বাকি হার্ট ফেলিওরগুলো সিমেন্টিক বা একাডেমিক জাগলারি। Now stages of heart failure. Stage A, at risk for heart failure. That means patient at risk for heart failure without current or previous symptoms, signs of heart failure, without structural and or functional abnormalities or heart disease or abnormal biomarkers. So stage 1, stage A, at risk for heart failure, but without current or previous symptoms, signs of heart failure, without structural and or functional heart disease or abnormal cardiac biomarkers. Examples: hypertension, diabetes mellitus, obesity, metabolic syndrome, exposure to cardiotoxins, family history of cardiomyopathy, and the CVD, that means cardiovascular diseases, especially peripheral arterial diseases and atherosclerotic disease. So stage A heart failure, that is heart failure at risk. Hypertension, atherosclerotic disease, obesity, diabetes mellitus, metabolic syndrome, exposure to cardiotoxin, family history of cardiomyopathy. Stage B, pre-heart failure without current or previous symptoms of heart failure, but evidence of any one of the following. Without current or previous symptoms of heart failure, but evidence of one of the following. 3. One key structural heart disease, যেমন left ventricular hypertrophy, previous myocardial infarction, valvular heart disease. Then evidence of increased filling pressures, then risk factors and increased natriuretic peptide levels or persistently elevated troponin levels in the absence of competing diagnosis. So stage B are pre-heart failure patients without current or previous symptoms of heart failure, but evidence of any one of the following 3. 1. Structural heart disease. 2. Evidence of increased filling pressure. 3. Risk factors and increased natriuretic peptides or persistently elevated cardiac troponin levels in the absence of competing diagnosis. Then stage C, symptomatic heart failure with current or previous symptoms, signs of heart failure. And stage D, that is the advanced heart failure, marked heart failure symptoms and signs that interfere with daily activity and that requires repeated hospitalization. So stage D, advanced heart failure, marked or severe heart failure symptoms and signs, and history of repeated hospitalization due to heart failure. Stage A by stage B, the management is very simple, only lifestyle modification and correction of the risk factors, nothing else. Stage C is very much important in the discussion of heart failure. So we want to know the trajectory of stage C heart failure. It may be new onset heart failure or de novo heart failure. That means newly diagnosed heart failure, no previous history of heart failure. 2. Resolution of the symptoms. Resolution of symptoms and signs of heart failure. Again, it can be categorized into 2 components. One is the stage C with previous symptoms of heart failure, persistent LV dysfunction, and heart failure in remission with resolution of previous structural and or functional heart disease. Then the next trajectory, persistent heart failure. Persistent heart failure with ongoing symptoms and signs and or limited functional capacity. Lastly, worsening heart failure, worsening symptoms, signs and limited capacity. The trajectory of stage C heart failure, new onset de novo heart failure, resolution of symptoms, then persistent heart failure, then worsening heart failure. Classification and trajectory of heart failure on the basis of LV ejection fraction. এক্ষেত্রে আমরা দুটো ভাগে ভাগ করে নিতে পারি। একটা হচ্ছে ইনিশিয়াল ক্লাসিফিকেশন, দেন সিরিয়াল অ্যাসেসমেন্ট অ্যান্ড রিক্লাসিফিকেশন। Initial classification, heart failure with reduced ejection fraction, HFrEF, LVEF less than equal to 40%, HF, MREF, LVF 41 to 49%, and HF, PF, LVF more than or equal to 50%. Serial assessment and reclassification. ECG বললাম heart failure with reduced ejection fraction that may be static, that is the LVF less than equal to 40%, or dynamic with improvement like heart failure with improved EF, LVEF more than 40%. Then the heart failure with mildly reduced ejection fraction, তার তিনটে ফেট হতে পারে। একটা হচ্ছে deterioration অর্থাৎ reduction to the range of less than equal to 40%, static, that is the same range 41 to 49%, and lastly the improvement LVF may be equal to or exceeding 50%. Lastly, the preserved ejection fraction, it may be static, that is the ejection fraction equal to or more than 50%. It may be deteriorating, it is less than equal to 40%, or it may be mildly reduced, that is in the range of 41 to 49%. This is the classification and trajectory of heart failure on the basis of LV ejection fraction. New York Heart Association functional class, class 1, limitation of activity nil. এখানে তিনটে প্যারামিটার থাকছে, ফাংশনাল ক্লাস, লিমিটেশন এবং ক্লিনিক্যাল অ্যাসেসমেন্ট। ফাংশনাল ক্লাস 1, limitation of activity none, clinical assessment. Ordinary physical activity does not produce undue fatigue, palpitation, dyspnea, or anginal chest pain. Stage 2, slight limitation of activity, comfortable at rest. Ordinary activity may result in fatigue, dyspnea, palpitation, or anginal chest pain. Class 3 is the marked comfortable at rest, less than ordinary activity leads to symptoms. And lastly, class 4, this is the severe symptoms of heart failure or angina at rest and worsened with any activity. সুতরাং stage, then LV ejection fraction, then the NYHA functional class, এই তিনটে জিনিসকে কাজে লাগাতে হবে আমাদের ম্যানেজমেন্ট অফ হার্ট ফেলিওরে। বাকি যে জিনিসগুলোর কথা বলা হয়েছে সেগুলো আগেই বলেছি, একাডেমিক জাগলারি। Now the adverse prognostic factors that may be structural, that may be clinical, structural, hemodynamic, biochemical, and electrophysiological, clinical or demographics, male sex, increasing age, diabetes mellitus, chronic kidney disease, coronary arterial disease, advanced NYHA class, then presence of S3 or elevated jugular venous pressure, decreased exercise capacity, then cardiac cachexia, and lastly depression. This is the clinical or demographic criteria. Then the structural, reduction in the RV ejection fraction, reduction in LV ejection fraction, then increased ventricular volumes and mass, and secondary mitral or tricuspid regurgitation. This is the structural criteria. And the hemodynamic, elevated pulmonary capillary wedge pressure, that means PCWP. Then reduced cardiac index, reduced peak oxygen consumption, pulmonary arterial hypertension, and then diastolic dysfunction. Elevated pulmonary capillary wedge, reduced cardiac index, reduced oxygen consumption, pulmonary hypertension, diastolic dysfunction. Biochemical, worsening renal function. Hyponatremia, hyperuricemia, elevated cardiac biomarkers like BNP or NT-proBNP, and elevated plasma neurohormones, norepinephrine, renin, aldosterone, and endothelin-1. Lastly, electrocardiographic tachycardia, wide QRS complex, then the atrial fibrillation, ventricular premature activity, or ventricular tachycardia. So adverse prognostic factors are clinical, structural, hemodynamic, biochemical, and electrophysiological. Acute heart failure and chronic heart failure. Acute heart failure এর আরেকটা নাম হচ্ছে acute decompensated heart failure, অথবা বলা যেতে পারে the rapid onset or worsening of symptoms and signs of heart failure. Most episodes of acute heart failure is due to worsening of the chronic heart failure. Only 20% are due to the acute coronary syndrome, acute valvular dysfunction, hypertensive emergency, and the post-cardiotomy syndrome. So 80% of acute heart failure is a result of worsening of chronic heart failure. Only 20% occurs in a setting of acute coronary syndrome, acute valvular dysfunction, hypertensive crisis, or hypertensive emergency, and post-cardiotomy syndrome. Diagnosis, pathophysiology, and management of acute heart failure. Pathophysiology of acute heart failure is virtually a complex interaction between a substrate, triggering factors, and amplifying mechanisms that may result in or contribute to a common set of symptoms and signs mainly related to congestion and hypoperfusion or end organ dysfunction or both that define the clinical picture of heart failure. A complex interaction between substrate, triggering factors, amplifying mechanisms, and ultimately contribute to a common set of symptoms and signs mainly related to congestion and end organ dysfunction or hypoperfusion or both that constitute the clinical picture of acute heart failure. This is a substrate. Acute heart failure occurs in a normal heart or in a presence of structural heart disease or worsening of chronic heart failure. What are the triggers? Hypertension, acute coronary syndrome, arrhythmias, infection, renal dysfunction, non-adherence, and medications. What are the amplifying mechanisms? It is the myocardial, renal, vascular, neurohormonal. Myocardial, decreased cardiac output, diastolic dysfunction, myocyte injury, mitral regurgitation, ventricular interdependence, and lastly, tachycardia. What is renal? Renal salt and volume retention, acute kidney injury, and RAS activation, renin angiotensin aldosterone system activation. What are the vascular components? Endothelial dysfunction, increased arterial wall thickness or stiffness, vasoconstriction, after load contractility mismatch, and volume redistribution, lastly capillary leakage. And what are the components of the neurohormonal? RAS activation, sympathetic nervous system dysregulation, oxidative stress, and the cardioinflammation or metabolic inflammation. So amplifying mechanisms are myocardial, renal, vascular, neurohormonal. The end result is congestion, end organ dysfunction, a common set of symptoms and signs that constitute the clinical picture of acute heart failure management. Initial evaluation. Initial evaluation of acute heart failure. First, establishment of a definitive diagnosis of acute heart failure. Then, emergent treatment of life-threatening conditions like cardiogenic shock and respiratory failure. Then, identification of any relevant triggering factors like acute coronary syndrome or arrhythmias. Then, risk stratification in an attempt to trace the patient at the optimum level of care, whether in the ICU or in the general bed or in the clinics. And lastly, the clinical profile on the basis of blood pressure, volume status, and renal function. So establishment of a definitive diagnosis. Second, emergent therapy for life-threatening conditions. Third, identification of relevant clinical triggers. Then, the risk stratification. Lastly, a clinical classification. Acute heart failure classical কোনো classification নেই, তো the classification of acute heart failure এর মধ্যে কয়েকটা পার্টিকুলার ডোমেনের কথা মাথায় রাখতে হয়। তার মধ্যে একটা হচ্ছে সাবস্ট্রেট, সেটা কি বলেছি স্ট্রাকচারাল হার্ট ডিজিজ থাকতে পারে, সেখানে বলেছিলাম যে ক্রনিক হার্ট ফেলিওর সেটিং এ হতে পারে। সেকেন্ড বলেছি সিভিয়ারিটি, দ্যাট মিনস মাইল্ড সিমটমস টু কার্ডিওজেনিক শক। Then acuity, gradual versus acute or sudden onset. Then the triggers which may be readily apparent or hidden. So the domains of classification of acute heart failure include substrate, severity, acuity, and the triggers. And a schematic representation chart sheet. Substrate, normal, structural heart disease, existing heart failure. Temporal profile, sudden, minutes to hours, subacute, days to weeks. Severity and location, shock, ICU, moderate, hospital, mild, clinic. Then triggers, cardiovascular, renal, and neurohormonal, or myocardial, renal, vascular, and neurohormonal already discussed. আজকে এই থাক নাকি? এইটা বলিনি ম্যানেজমেন্টকে আগেই বলেছি এভালুয়েশন করতে গিয়ে ফার্স্ট হচ্ছে যে লাইফ থ্রেটেনিং কন্ডিশন আছে কিনা এইগুলো দেখে রেখে clinical suspicion of acute heart failure. First, urgent phase, that is the just first medical contact. Cardiogenic shock, yes. Support to circulation, pharmacologic or mechanical. No. Respiratory failure, yes. Support to ventilation. Oxygen, non-invasive ventilation or mechanical ventilation. No. Immediate phase, initial 60 to 120 minutes. Identification of acute etiology, CHAMP. C. Acute coronary syndrome. H. Hypertensive emergency. A. Arrhythmias. M. Mechanical complications like mitral regurgitation or tricuspid regurgitation. And P. Pulmonary embolism. No diagnostic workup to confirm the heart failure. Yes. Institution of the specific therapy. আচ্ছা, অনেক আগে বলা হয়েছিল যে হার্ট ফেলিওরের ক্ষেত্রে, বিশেষ করে অ্যাকিউট হার্ট ফেলিওরে, যে কমপ্লেক্স ইন্টারফ্লে কথাটা বলার পর বলা হয়েছিল কমন সেট অফ সাইনস অ্যান্ড সিমটমস, যেটাকে বলা হয়েছিল মেনলি কনজেশন আর বলা হয়েছিল হাইপোপারফিউশন। এই দুটোর উপর বেস করে আমাকে অ্যাসেস করতে হবে।